This is chapter 27, Behavioral and Psychiatric Emergencies, and we're going to talk about suicide here as well. Behavior refers to the way somebody acts, and we call behavioral emergencies when that behavior is unacceptable or intolerable, and that can be to the person's family, to the community. We do need to use some cultural awareness here because there may be some behaviors that are odd or bizarre to us, but it may be part of their culture. So be sure that you are intervening appropriately. Behavioral conditions need a full assessment, just like every other patient. We don't want to overlook anything. We've got to ensure what's happening with this patient and if we can identify any other potential causes for this behavior. Please remain objective. We are not judgmental. We just want what's best for the patient. Observable behaviors are things you're obviously going to be able to see. And this is because of neurotransmitters typically misfiring inside the brain. These neurotransmitters move from neuron to neuron, and the neuron, if you remember, is that one cell within the brain, and again, travels between neurons. These impulses move across the nervous system by this mechanism, creating these behaviors. Sometimes the problem lies with the neurotransmitters. Sometimes it's because there's a lack of neurotransmitters where we don't get complete signals going through. This has been seen in depression and other psychiatric disorders. Medications can be prescribed for these conditions and can help the patient manage the condition. Newer medications are coming out there which help with reuptake, inhibition of more than one neurotransmitter. These medications hopefully will be told to you, or you will find the medication bottles. Be sure that you take them with you to the hospital so that all of their medications are identified. And if we know what kind of medication it is, even if the patient cannot communicate to us why they take it, we may be able to figure that out. Psychiatric conditions or mental health, mental disorders can be behavioral as well. We need to understand that 1 in 5 adults in the US has a mental illness, whether that's anxiety or depression or schizophrenia. There are a lot of mental health conditions out there, and we need to treat this as if it were a medical condition. If someone's having a heart attack, they go to the hospital. If someone's having a psychiatric emergency, they need to go to the hospital. Mental health services are difficult to come by. We have very few psychologists out there that do inpatient. Finding beds for some of these patients can be different, but we have to do our best for them, which is why we've got probably so many in the community, because there's less and less space for them in those designated living quarters. So let's truly assess what's going on with this patient. We know that patients can act oddly for a variety of reasons. They may be having some type of behavioral or psychiatric emergency, but they could also be experiencing a medical or trauma emergency, low blood sugar, hypoxia, a stroke, trauma to the head, or a head injury, seizures, substances that have caused them to be altered, or exposures to extreme temperatures. Individuals can respond differently to different things in their life. This is called situational stress reactions. When we have a situational stress reaction, The person can go through a variety of emotions, fear, grief, anger, and they can flip from one to another quickly. Sometimes it's very difficult to anticipate what to expect. So as we are caring for this individual, take your time. The more rushed or agitated you appear, the more likely they are to become angry and agitated. Tell the patient why you're there, that you are there to help them, and remain calm. Keep the emotions under control and just listen. Sometimes silence is okay as well. Be honest with them, let them know where you are taking them, but be alert for any changes in their behavior so that you can react appropriately. Acute psychosis, this is relatively rare, but basically this is a loss of the patient's ability to process information and interact with the environment. We see this sometimes with schizophrenia. The patient just kind of shuts down. They stop responding. They are in their own world, and it can take some time to get them to respond. Some patients with schizophrenia may go through these acute psychosis phases that may last hours to days. Again, the patient has no real understanding and cannot respond well to their environment or the things around them. They're likely having hallucinations and delusions. They may be completely catatonic, meaning they're unresponsive, but their eyes may be open and they look alert. They may have thought disorders and think things in an inappropriate way. They may not be able to sequence events, and so that makes them a threat. And if we push them, again, they're going to flip and potentially become aggressive. So we need to make sure that we are safe, the patient is safe, and that we take care of them appropriately. So it's not hard to do, and even not being EMTs yet, you probably already do this to some degree, but you assess the people around you. How do they look? Are they withdrawn? Are they communicating? Are they talking really fast? Do they appear agitated? Are they doing odd or bizarre behaviors? Do they voice or show any concerns for harming themselves or others? These are things we need to particularly be watching in those patients with behavioral and psychiatric emergencies. As we begin to interact with the patient, be sure that you identify yourself. Tell them why you are there. We many times wear a uniform, and depending on your service, you may even have a shiny silver badge on your shirt. So we don't always look like EMS responders. We may look like police officers or other professions. So make sure the patient understands what you're there for. Speak slowly and clearly. Be sure that they understand you. Make eye contact and listen. We sometimes need to close our mouths and just let the patient talk or vent. We do not want to be judgmental, and again, explain to the patient, we just want what's best for them. As you're talking to the patient, be aware of your nonverbals. And what I mean by nonverbals is your body language. Are your arms crossed? Are you at eye level? Or are you standing over the patient like an authority figure? You want to appear and be empathetic with the patient, listening to them and acknowledging their feelings. Try to stay at least 3 feet away from the patient. We do not want to enter their space, their personal space, and if they do become agitated, we want to really be out of the range of their grab or their kick. Be alert for changes in their emotional status. Again, they can go from calm and withdrawn 1 minute to agitated the next. And we don't like to use restraints if we don't have to, but sometimes the situation calls for it because the patient is uncontrollable and is likely to hurt one of us or themselves. So this is in a perfect world, right? We see the patient who's having a psychiatric emergency being surrounded by 4 EMTs. This is so that we can have each person available to grab an arm or a leg. If each person has one extremity, we can control the patient better. If we have a 5th rescuer, they can help to manage the patient's head so that they aren't hitting their head on anything or trying to, be aggressive in that manner. But do be careful because patients can bite. So while you're on scene, don't forget to look around. Make sure that you know that the scene is safe as you arrive and you approach the patient. Identify yourself and your role. Get your primary assessment. And as long as everything checks out, we move on to that more detailed exam or the secondary assessment where we're going to ask all of the history questions, sample history or OPQRST or medications or drugs that they may have taken. Patients having psychiatric emergencies may be very anxious or act like they are panicked. This patient may have been suffering from this psychiatric emergency for days. So look at their appearance. Does anything look off? Is their hygiene good? Have they showered? Are their clothes dirty or disheveled? Is the patient agitated? Do we see any unusual activity or movements? What is their speech pattern like? Is the patient able to speak clearly to you and answer your questions? Or are they difficult to understand or almost sound like they're speaking in a foreign language? Bizarre behaviors and thought patterns are common. These patients also are likely to have self-destructive behaviors and may even commit suicide. Violence or aggressive behavior can be common among these individuals, especially if they begin to feel threatened. So make sure we continue to evaluate the situation. So be alert for your personal safety. Think about any life threats or potential life threats that the patient is dealing with. Make sure we treat them first. Think about any potential underlying causes for the patient's odd behavior. Were they just in a car accident and maybe have some head trauma? Are they diabetic and maybe their blood sugar is off? Or maybe they have a history of psychiatric problems. Spend time talking with them. Do not make them feel rushed and listen to them. Acknowledge their feelings. Do not play along with hallucinations or delusions. When we talk about hallucinations or delusions, it's usually trying just to keep the patient calm and try to refocus them on something else. Consider involving family or friends, and I say that cautiously because we don't want children being in an unsafe environment or being exposed to things that they really shouldn't have to deal with at this point in time. But other family members may be able to calm the patient and keep them kind of under control. Suicide is a serious topic, and especially in the world of first responders, but it is the 10th leading cause of death in the United States. We know that individuals sometimes have a mental health issue like depression, and that can cause them to be more successful in their suicide attempts. We see this with combat veterans. We see this in the senior citizen population because all their friends are dying or their significant other has passed away. We also see this in what we do because of the trauma that we have to experience and help with every single day. Many more people suffer both physical and emotional injuries, and people will attempt suicide, and if they are unsuccessful and they survive, they may have lasting effects. Anyone may become suicidal when they reach that point, when they reach their breaking point, and that's going to be different for different people. So people are likely to attempt suicide for different reasons, and again, it's not for us to judge if they should or should not have attempted it, but we want to take care of them and help them to survive. Some things that we kind of watch for if we're trying to identify potential or attempted suicide. The patient may be having some periods of depression recently. They may have some high stress situation going on at the moment. It may be with family, it may be with work, it may be financial, it could be related to, again, many different things. Maybe they've experienced some emotional trauma, a loss of a loved one, or a divorce. Age 15 to 25 and age 40 and up are the highest risks. Drugs and alcohol can sometimes be involved. They may be used to help lessen the patient's feelings, or they may be used to assist with the suicide. Be sure that you are listening to your patient and you understand the things that they are saying. If they do make threats of suicide, or they state they have a plan to kill themselves, then we need to make sure that we alert the appropriate people so that the patient can be continually monitored and receive the help that they need. Previous attempts or threats may mean the patient is going to try again. And sudden improvement from depression. If we have a patient who has been very depressed and now out of nowhere they just seem like the world is right again, these people may be acting that way because they have a plan and they know that once they follow through with their plan, then things will be over. There are many different ways that patients will try to harm themselves, and you need to make sure that your safety comes first. So if the patient says to you that they have a bomb or something of that sort where you may be injured, then you need to back away, try to keep visual eyes on the patient, but we also need to call for some extra resources. So do your scene size up, identify and treat any life threats, reassure your patient, do your secondary assessment, reassess them frequently, and make sure that we identify what is coming in to the hospital so that they can have the appropriate individuals to assist with this patient. All right, so here we go. We got a 23-year-old man. His girlfriend has called 911 because they got into a fight. He is being uncooperative. He's refusing any treatment from us, but the girlfriend is concerned because she says he's been depressed and suicidal. The patient owns a gun and he has threatened to shoot himself. So let's think about it. Can we treat the patient if he is not the one that called? Absolutely. Should we believe the girlfriend? Well, we should believe her, but we need to speak to the patient as well. We want the patient to talk to us. We want them to answer some questions and maybe tell their side of the situation. Does the patient need treatment or transport? Absolutely. The patient has made a threat and has the means. We do not want to leave them alone. We would like to help them get the support that they need. Can you treat and transport the patient against his will? If he is making those threats to harm himself, we can. However, I want to caution you This is not a wrestling match between us and the patient. We need to call law enforcement to assist us. So what should we do? Try to talk to the patient. Reassure them that you're there to help. Listen to them quietly. Let them tell you their feelings, and explain to them that there are resources that will benefit them. So this rolls into our aggressive or hostile patients. Look at what's going on. Ask dispatch if there is any concerns. If this is a domestic dispute, if there is a weapon, many times dispatch is going to relay that information to you before you even arrive. But there may be additional clues on scene. Information from family or neighbors, anyone who is around, may be helpful. And the patient's stance or their position in the room may help us to decide if the scene is safe. We need to be sure that we have a way out. And it's difficult when we go into people's homes because we may have never been there before and we don't know where all of the exits are. So be sure that the door is always at your back and you are between the patient and the door so you can escape quickly if needed. Do not threaten the patient. We want them to understand we're there to help them. We are not here to penalize them, but we need to get them the support that they will benefit from. And be aware for any weapons. At all times, remember, this is a fluid situation. It can change, and they may just reach under the couch and pull a gun out. We don't know. So assessing these patients can be difficult. We want to be sure that our primary assessment is good, airway, breathing, circulation are intact, but we would prefer to wait for the patient to settle down a little bit, calm down, before we move on with our assessment. However, we've got to do a full assessment on every patient. So we may have to move this along, use our words, and again, reassure the patient, but get the information that we need at the same time. So that emergency care is going to include that scene size up, asking for additional resources or help based off of the situation. Get some extra advice from medical control. Watch for any changes in behavior. Reassess the patient frequently, and if needed, consider restraints. So when do we get to use these restraints? Well, reasonable force and restraints are using the force needed to keep the patient safe from themselves or from hurting others. So when we say reasonable force, that's going to be based off of each situation. The patient's size and strength may be a concern, the type of behavior or the threats that they're making. What's their mental status? Can we even talk with them, or are they very combative and not making much sense? And what are the available methods of restraint? So we do have physical restraints for the arms and the legs, but there are chemical restraints as well that the paramedics can use if needed. So when we need to use that reasonable force, most EMS services understand that it's for our safety and they are agreeable to allow us to do that. But never attempt restraint without understanding the legal authority or ramifications of it. We've got to make sure we have enough people and that we do it correctly for the right reasons, or the patient may still hurt themselves or we could be prosecuted. Excited delirium is a situation where you may have to use that reasonable force and restraint. So excited delirium is an extremely agitated or psychotic behavior from a patient. This can be triggered from different things, including uncontrolled psychiatric disorders and or drug use. These patients are usually diaphoretic, they're sweating like crazy, their skin is hot, they're speaking very rapidly, not making much sense, saying off the wall things, and I will tell you that many times these patients are found naked. So it's important to understand that this situation actually causes life-threatening cardiovascular and metabolic stress. These patients can die if they are not cared for appropriately, and we need to get them to the hospital to receive that care. Positional asphyxia is where the patient has inadequate breathing or respiratory arrest because of their body positioning and not being able to breathe. This is why we do not restrain patients or transport patients on their belly. If they are in the prone position, then they are at an increased risk for positional asphyxia. When you see the individuals, police officers and that, wrestling with someone and they're kneeling on their back, that could lead to positional asphyxia because it limits the amount of chest movement for breathing. So they have to be careful in the way that they do it, and we are not trained to do that type of restraint, so don't do it. So if our patient needs restraining, then we need to make sure that we have adequate help. We can't go in, halfway get it done, and then retreat. We've got to have an action plan, and we've got to act quickly. Everyone moves in together. One EMT does the talking to the patient. We don't need 4 or 5 people all yelling or talking over each other. It becomes a very chaotic mess. Normally, this is going to require 4 people, but if you have extra, that's fantastic. The idea is we want 1 person for each limb. We are going to restrain those limbs with the appropriate restraints. We have leather restraints. We also have soft restraints. And we always will restrain them in the supine position. Supine is on their back. If the patient is restrained, we've got to ensure that their airway stays open. We've got to make sure that the patient is secured throughout the transport so that they are not going to have any harm come to them during the drive to the hospital. Sometimes patients are very upset when they get restrained. They may begin to spit, and that's their only defense. So we can put a surgical mask on them if your protocols allow. We can also make sure that we have a mask on ourselves and eye protection. Reassess the patient frequently though. Make sure you are looking for any changes in their condition. This does not mean we're going to release the restraints, but it just means that we are identifying if the patient is improving in their condition or if they are deteriorating more. Don't forget to document it. Document everything. You can even include quotes of what the patient said. Behavioral emergencies are unique, kind of like a trauma center at a hospital is for trauma patients. Not all hospitals have the capabilities to care for these behavioral emergencies. So it's really important that we try to go to the closest, most appropriate facility that can handle this particular patient. You should know what your local resources are and what the different institutions have to offer. So it all comes down to what's legal and what's not. Refusals and restraints can be really difficult situations. We worry for someone coming back and suing the system. And laws are typically there to help protect us so that we can treat and manage the patient. But be sure that you understand the laws and the protocols in which you are to follow. Something that you need to be warned of is the potential complaint of sexual misconduct. Sometimes behavioral patients will accuse EMS providers of sexual misconduct in the back of the ambulance, whether they say that you touched them inappropriately or said something inappropriately. It's wise to have the same-sex provider attend to the patient if you can. For aggressive or violent patients, make sure that we have a police officer with us so that they can help keep the environment safe for us. We do want to protect the patient. We do want to get the patient taken care of, but if we have a situation where the patient is making complaints against the provider, it's important that having that third person there to witness what actually occurred may be helpful. Many ambulance services also have cameras in their ambulances to help with any legal situations that might arise. You are bound to go on a call with a behavioral emergency. Remember, we need to be professional, but our safety comes first. We know that mental health is a serious problem and it can be life-threatening for patients. We want to react appropriately with these patients. Not everyone is going to be violent, but just listening and reassuring the patient is powerful medicine. Understand that not everything is always black and white. And you may have a patient who is having some bizarre behaviors, and unfortunately, it may not be due to a psychiatric issue. It may be due to a medical or traumatic injury. Psychiatric disorders or mental health issues are things that usually require more of a long-term management. They aren't just going to go into the doctor's office, get a shot, and they're all better. They may have to take daily medications. They may go through therapy. But the way that we interact with the patient can set up how things are going to continue to play out. So we want to continue to reassess the patient and remain professional throughout our entire time with the patient. Safety first, and understand that this is a serious problem and many people deal with mental health issues. Try to identify what's going on with the patient, and if this is a medical, a trauma, or true psychiatric issue. We know that patients can present differently, but that's why we've got to develop good assessment skills so that we can assess and reassess the patient, adapting to any changes. When caring for these patients, make sure that you understand your protocols and that you follow them. This includes restraining patients. So some questions to consider. What can you do to calm a patient that is having this behavioral or psychiatric emergency? Well, we want to talk to them like they're human, tell them who we are and what we are there for. Explain to them that we just want what's best for them, and listen. Be quiet and just listen. What can you do when the scene size up says that, hey, it's dangerous? Then we need to back off. We need to move back to a safe place and call in some additional resources. What factors help assess the patient's risk for suicide? As we look at the patient and we try to determine if they're truly suicidal, it's watching their body mechanics, listening to what they say. When they say, I have a gun, or I'm going to drive my car off of a cliff, those would absolutely be red flags. And remember, the patient who has been depressed, that all of a sudden is happy and has no issues or concerns, that patient is also a red flag. So here is a unique situation. You're called to an intoxicated minor who is physically aggressive and is threatening suicide. The parents of this child called you and they want you to treat the patient, but they do not want you to transport the patient to the hospital. How are you going to manage this patient? What should you do next? Well, after speaking with the parents and trying to rationalize the situation with them to get their consent, if we are not getting anywhere, this is a situation where law enforcement needs to be involved. We have a minor who is intoxicated, and we've got parents who are not allowing him or her to get the treatment that they need. So law enforcement can come in and assist us to take the patient out of the home and transport them up to the appropriate facility. And that wraps up chapter 27.